Imagine a disease that is entirely 100% preventable. A disease caused by an organism you could, easily find just sitting in the dirt outside your window right now.
Right.
And yet if this microscopic organism finds its way into your body, it orchestrates a hostile takeover of your nervous system so violently that it carries a staggering 20 to 50% fatality rate globally. I mean, today we aren't looking at some novel, unmapped virus. We're looking at an ancient enemy.
Yeah, we really are. We are unpacking a remarkably dense, highly detailed medical presentation on the management of post-neonatal tetanus.
Hmm.
Our mission for this deep dive today is to give you, the listener, an exhaustive, uncompromising look at this formidable condition. We're going to trace the entire life cycle of this disease, starting from a dormant spore, just waiting in the soil.
Just waiting.
Exactly. Mapping its devastating journey through the human nervous system, and ultimately breaking down the exact minute-by-minute clinical management protocols required to save a human life in a modern intensive care setting.
Let's set the stage first, because the sheer scale of the threat feels contradictory to how we usually talk about tetanus.
Sure.
When I hear the word, my mind immediately jumps to, like, stepping on a rusty nail, running to the local pharmacy for a quick shot, and then forgetting about it entirely.
Right, the classic trope.
Yeah. So a 20 to 50% fatality rate feels astronomically high for something we treat as a minor childhood rite of passage. What does the actual global battlefield look like today?
Well, the global incidence rate sits at roughly 18 cases per 100,000 people every single year.
Wow.
And when you extrapolate that across the global population, you're looking at an immense ongoing public health crisis. It remains a deeply serious problem in developing countries, whereas in the United States, widespread aggressive vaccination campaigns have driven the incidence down so far that it borders on a medical rarity in many hospital systems.
Which perfectly explains the blind spot, right? If you live in an area with high vaccination compliance, you simply never see the consequences. But the underlying vulnerabilities haven't changed at all.
Not at all. The risk factors are universally consistent, regardless of geography. The text outlines them very clearly. Being unvaccinated, being improperly or incompletely vaccinated, or, and this is a big one, suffering from inadequate wound hygiene.
Right.
If a patient falls into any of those three categories, the door is wide open for the organism.
That phrase, inadequate wound hygiene, it feels almost deceptively simple, like you just forgot to wash a scraped knee.
Exactly, yeah.
But the source material highlights a very specific, fascinating study that completely shattered my preconceived notions of what a wound even means in the context of tetanus.
You're referring to the 1989 to 1992 study conducted at UCH, the University College Hospital.
Yes.
The researchers there were attempting to map the exact portal of entry for 38 documented cases of tetanus. They wanted empirical data on how physically the disease was breaching the body's defenses.
And the breakdown is incredible to look at. I mean, of those 38 cases, 50%, so that's 19 cases, originated from what we would consider typical wounds.
Right.
Punctures, deep cuts, severe scrapes. That aligns perfectly with the rusty nail scenario.
It's the expected traditional pathway, yeah.
But the second largest category completely threw me. 13 cases, which accounts for a massive 34.2% of the total patient pool, contracted tetanus through otitis media.
Middle ear infections.
Over a third of the cases. Think about how mundane an earache is.
Yeah.
How on earth does a standard, incredibly common middle ear infection serve as a gateway for a lethal neurological pathogen?
It's wild, isn't it?
It is. And we also saw chronic ulcers, making up 13.2%. That's 5 cases. And circumcision, accounting for 1 case, or 2.6%.
Yeah.
But the ear infection data is terrifying because it's just so common.
It forces a complete reevaluation of how we view vulnerable tissue. You see, in environments with limited access to immediate medical care or antibiotics, a middle ear infection doesn't just resolve.
Right.
The pressure builds, the eardrum can physically rupture, and you are left with a chronic, draining, open wound located deep inside the ear canal.
Oh, wow.
And if a child with a draining ear is, playing outside, getting dirt on their hands and touching their ear, they're introducing soil directly into an exposed necrotic environment.
The mundane nature of that scenario is just chilling. A kid playing outside with a runny ear.
Yeah.
So we have these wildly different physical entry points. A puncture on the sole of the foot, a chronic skin ulcer, a ruptured eardrum from an infection.
Right.
To understand how such varied portals lead to the exact same catastrophic neurological failure, we have to isolate the culprit, Like, what is actually crossing the threshold into these wounds?
The organism responsible is a bacterium called Clostridium tetani. Microbiologically, it's classified as a gram-positive obligate anaerobe.
Okay, let's translate that for someone without a microbiology background, because obligate anaerobe is a very specific lifestyle for a bacterium.
Yeah, obligate means it is absolutely restricted to a specific set of conditions to survive. And anaerobe dictates that the condition must be completely devoid of oxygen.
Completely devoid.
Entirely. Oxygen is lethal to the active, growing form of this bacteria. It simply cannot function in the presence of normal atmospheric air.
That feels like a massive evolutionary disadvantage. I mean, how does an organism that dies when exposed to air manage to be one of the most ubiquitous threats on the planet?
Because of where it naturally thrives and how it adapts when it leaves those safe zones, Clostridium tetani lives extensively in the soil. It's also a natural resident in the intestines of horses, sheep, cattle, rats, dogs, and chickens.
Okay.
And remarkably, the text notes it's even found as part of the normal intestinal flora in about 10% of humans.
Wait, 10% of the human population is just walking around with tetanus bacteria living harmlessly in their gut.
Exactly, because the intestinal tract is an anaerobic environment. Deep inside the gut, there's no oxygen, so the bacteria is perfectly content. And under a microscope, the active bacteria is quite distinctive. The source material describes it as having a terminal rod, which gives the cell a very recognizable shape, closely resembling a tiny tennis racket.
But when that microscopic tennis racket is expelled from the safe, oxygen-free gut of an animal and lands in a sunlit, oxygen-rich patch of soil, it shouldn't survive. It should die instantly.
And the active vegetative form does die. The vegetative cell is incredibly fragile, it's highly sensitive to heat, and as we established, oxygen destroys it.
Right.
But C. tetani possesses a secondary phase to its life cycle, a survival mechanism of unparalleled resilience. As the environment becomes hostile, the bacteria forms a spore.
The text description of this spore is staggering. It is essentially an indestructible biological vault. The vegetative bacteria packs its genetic material into this spore and shuts down, waiting.
Yes.
And the durability of the spore is almost beyond belief.
The source material lists exactly what it takes to destroy the spore form, and it perfectly illustrates why the organism is impossible to eradicate from the environment. The spores resist extreme heat. They resist standard medical antiseptics. They remain completely viable after exposure to harsh chemical agents.
The text states that if you want to definitively kill a tetanus spore, you have to place it in an autoclave, which blasts it with highly pressurized steam at a temperature of 120 degrees Celsius for 15 uninterrupted minutes.
Or, if an autoclave is unavailable, the alternative sterilization method provided in the text is boiling the contaminated item for at least 4 straight hours.
4 hours in violently boiling water. I mean, if you drop almost any biological material into boiling water, the cellular structures denature and disintegrate in seconds, maybe minutes.
Oh, absolutely.
This spore can sit in a rolling boil for 3 hours and 59 minutes, and if you pull it out and put it in a wound, it can still kill you.
When you grasp the sheer physical resilience of the spore coat, the epidemiology suddenly makes perfect sense. The spores are ubiquitous. They are in the dust, in the dirt, in agricultural areas, waiting indefinitely.
Right.
They only require one very specific trigger to abandon their armor and return to life.
They need an environment that mimics the gut, a place with absolutely zero oxygen, which brings us right back to our portals of entry.
Really.
A superficial scrape on the knee bleeds, it's exposed to the air, and the oxygen kills any tetanus bacteria that try to grow. But a puncture from a nail goes deep into the tissue. The tissue closes over the top, the blood supply is damaged, and deep inside that wound, an oxygen-deprived pocket is created.
And the exact same anaerobic conditions are found beneath the dead tissue of a chronic ulcer, or deep inside the purulent necrotic environment of a ruptured, infected middle ear.
Wow.
Once the spore senses that the oxygen is gone, the waiting is over. It germinates. The indestructible armor falls away, and the fragile, active, vegetative bacteria begins to rapidly multiply within the wound.
So the breach has occurred. The dormant threat is now an active infection, multiplying inside a deep tissue pocket. How do we get from a localized pocket of bacteria in your foot or your ear to a catastrophic failure of the central nervous system?
This transition is the pathogenesis of the disease. As the vegetative C. tetani multiply in the anaerobic wound, their metabolic processes produce and release two distinct toxins.
Okay.
The first is called tetanolysin, and the second, the one responsible for the entire clinical nightmare of the disease, is called tetanospasmin.
Tetanospasmin. Even the name carries a certain weight.
It is widely considered by microbiologists to be one of the most potent neurotoxins ever discovered. The active bacteria remain localized in the wound. They do not invade the rest of the body.
Oh, they don't?
No, they stay put. But the toxins they release disseminate. They enter the bloodstream and the lymphatic system, using the body's own circulatory highways to search for their targets.
So the toxin's just circulating, waiting to bump into a nerve.
Its ultimate destinations are the spinal cord, the brainstem, peripheral nerves, and the neuromuscular junctions, the exact points where nerves connect to muscle fibers.
Right.
The mechanism the toxin uses to travel from the muscle back to the central nervous system is incredibly insidious. The text defines the process as retrograde axonal transport and transsynaptic spread along the motor nerve trunks.
Let's break down retrograde axonal transport, because the physics of it are bizarre. Usually, a motor nerve functions like a one-way street. Your brain sends an electrical signal down the spinal cord, down the length of the nerve axon, and out to the muscle, telling it to move.
The flow of information is from the center, outward.
But the toxin does the exact opposite.
Yeah.
It finds the very end of the motor nerve where it touches the muscle, it slips inside the nerve fiber itself, and it physically travels backward retrograde, climbing up the inside of the nerve cable, completely bypassing the protective blood-brain barrier until it reaches the spinal cord and the brainstem.
It utilizes the body's own infrastructure to deliver the sabotage directly to the central command center.
That is terrifying.
And once tetanospasmin reaches the synapses in the central nervous system, it executes a highly specific biochemical attack. The text explains that the toxin alters synaptic function by definitively blocking the release of two vital inhibitory neurotransmitters, GABA and glycine.
This is the absolute core of the disease. So let's visualize what blocking GABA and glycine actually means for a patient. Think of your muscular system like a high-performance sports car.
Okay.
Your motor neurons, the nerves telling your muscles to contract, are the accelerator pedal. They constantly want to push the gas and make the muscles fire.
And in a healthy nervous system, GABA and glycine function as the brakes.
Exactly. Your brain relies on those chemical brakes to keep the system manageable. When you're sitting still, the brakes are applied so your muscles stay relaxed. When you reach for a glass of water, your brain carefully balances the gas and the brakes to make your arm movement smooth and precise.
It's a delicate, constant modulation of excitatory and inhibitory signals.
But tetanospasmin doesn't push the gas pedal. It literally sneaks into the engine and severs the brake lines. It destroys the mechanism that releases GABA and glycine.
So wait, the muscles are just receiving a nonstop signal to flex.
Yes. The clinical terminology in the text for this event is disinhibited motor neurons. Because the inhibitory signals are completely gone, the motor neurons default to their natural state of firing. But now they fire continuously.
Wow.
The result is a sustained excitatory discharge bombarding the muscles with relentless commands to contract.
The muscles are receiving a non-stop, high-voltage signal to flex with maximum force, and the brain has absolutely no way to send the signal to stop.
This sustained discharge creates an intensely increased baseline muscle tone, presenting as severe, unyielding rigidity. But the baseline rigidity is only the foundation. Layered on top of that constant tension are paroxysmal exacerbations, violent, sudden, full-body spasms.
And what triggers these massive spasms if the brain isn't intentionally sending a signal? Because the inhibitory control is gone, the nervous system becomes hyperreactive. The spasms can occur completely spontaneously, or they can be provoked by the slightest sensory input.
A completely benign stimulus, like a light turning on, gets interpreted by this broken system as a reason to fire every muscle in the body simultaneously.
The hypersensitivity is extreme, but, the text reveals a profound paradox regarding this physiological sabotage. Despite the violence of the toxin and the catastrophic failure of the nervous system's regulatory controls, the disease is ultimately self-limiting and entirely reversible.
Wait, if the toxin physically destroys the mechanism that releases the neurotransmitters, how is it reversible? You just said the brake lines are severed.
They are severed, but the nerve cell itself is not dead. Tetanospasmin binds irreversibly to the nerve endings. The specific protein complexes responsible for releasing GABA are destroyed. To recover, the body has to physically synthesize brand new presynaptic components, package them, and transport them all the way down the length of the axon to rebuild the nerve ending from scratch.
The body has to manufacture replacement brake lines and slowly reinstall them while the engine is running at 1,000 miles an hour.
It is a grueling biological process that takes weeks or even months. But if the patient can survive the physical trauma of the interim, they will recover with zero permanent neurological damage. The nerves heal completely.
The text also draws a very direct correlation between the timeline of this attack and the ultimate severity of the disease.
The rapidity of the onset is a critical metric. A short incubation period, meaning the time between the injury and the first symptom is very brief, indicates a massively severe case.
Right.
It suggests either an overwhelming amount of toxin was produced in the wound very quickly, or the patient's immune system offered absolutely no resistance.
We have mapped the microscopic journey. We know that toxin has traveled up the nerves, destroyed the release of GABA, and left the motor neurons firing relentlessly. Let's move from the microscopic view to the macroscopic reality. What does this catastrophic loss of chemical inhibition actually look like in a human being?
The clinical manifestations begin after an incubation period that the text notes typically spans 2 to 14 days. However, it explicitly states it can take up to a full month for symptoms to appear.
The psychological weight of that timeline is heavy. You could suffer a deep puncture wound, go through the painful process of cleaning it, watch the skin heal flawlessly over the next few weeks, and 30 days later, long after you've forgotten the injury, the spores germinate deep inside the healed tissue.
And intriguingly, in 33% of documented cases, the incubation period is entirely unknown. The patient simply cannot recall an injury.
Which perfectly aligns with the otitis media data. You don't view a mild earache as an injury with an incubation period.
Exactly. The initial warning signs, the prodromal symptoms, are tragically nonspecific. The text lists headache, restlessness, and irritability.
Symptoms that could easily be dismissed as stress, lack of sleep, or the onset of a common cold. You would never rush to the emergency room for irritability.
But the ambiguity quickly vanishes. The text categorizes two clinical variants: localized tetanus, where the rigidity is confined to the muscles near the wound, such as cephalic tetanus involving only the cranial nerves, and generalized tetanus.
And generalized is the most common and the most lethal trajectory.
Yes. The text maps the progression of generalized tetanus as cephalocaudal. It moves systematically from the head downward to the toes.
Why does it almost always start in the head and jaw?
Because the cranial nerves are the shortest. The toxin has a much shorter physical distance to travel via retrograde transport from the facial and jaw muscles to the brainstem than it does from a leg muscle to the lower spinal cord. Consequently, the jaw muscles lose their inhibition first.
I see.
This leads to the most famous presenting symptom, trismus, or lockjaw. The text notes this is the very first symptom in 50% of all cases.
The masseter muscles that control the jaw are incredibly powerful. When they are constantly stimulated to contract without any inhibitory breaks, the jaw clamps shut with a force that the patient simply cannot overcome.
Following the lockjaw, the cephalocaudal progression continues downward. The patient develops dysphagia, which is profound difficulty swallowing, as the muscles of the throat and esophagus become rigid. This is followed closely by severe neck stiffness.
The rigidity then spreads to the facial muscles, creating one of the most historically documented and visually disturbing signs of the disease, risus sardonicus.
The ironic or sardonic smile.
The human face has complex networks of opposing muscles designed for nuanced expression. When every single facial muscle receives a maximum contraction signal simultaneously, the strongest muscles overpower the weaker ones.
Right.
The lips are forcefully pulled back, the teeth are bared, and the eyebrows are drawn upward into a fixed, rigid grimace. The patient isn't smiling, their facial structure is locked in a tug-of-war.
As the descending paralysis reaches the torso, the abdominal wall becomes intensely rigid, often described in medical literature as board-like. But the most violent physical manifestation occurs when the massive muscle groups of the back, the lumbar region, the hips, and the thighs are fully engaged by the toxin.
The muscles of the human back are fundamentally stronger than the muscles of the chest and abdomen. They are designed to keep us upright against gravity. When both sides fire simultaneously with maximum force, the back muscles win.
This overwhelming disparity in muscle strength forces the body into a state called tetanus.
Imagine a patient lying flat on a hospital bed. When tetanus strikes, the back muscles contract so violently that the spine arches completely backward. The arch is so extreme that the patient's body lifts off the mattress entirely. The only points of contact remaining on the bed are the back of the patient's head and their heels.
It's horrific.
Their entire body weight is suspended in the air, bridged by the sheer unregulated force of their own rigid muscles.
And remember the hypersensitivity we discussed. These bone-breaking, breath-stopping spasms can be triggered by almost nothing. A gentle touch on the arm by a nurse, a sudden noise in the hallway, or even a draft of cool air from a vent moving across the skin is enough to send the patient into a full opistotonic crisis.
But of all the physiological horrors listed in the source text, there is one solitary bullet point that completely shifts the emotional gravity of the disease. It notes very plainly that throughout this entire ordeal, the patient remains completely conscious.
Because tetanospasmin is extraordinarily selective in its target, it only binds to and affects motor neurons. It has absolutely no effect on sensory nerves, and it does not cross into the areas of the brain that govern cortical function, thought, or awareness.
The psychological isolation of that is unbearable to contemplate. The patient is fully awake. Their cognitive function is completely intact. They can hear the doctors talking. They can feel the agonizing pain of their muscles tearing themselves apart, but they cannot speak, they cannot open their mouth to cry out, and they cannot stop the violent contortions of their own body. They are trapped inside a machine that is destroying itself.
It is the clinical definition of being locked in.
When a patient arrives in an emergency room, presenting with symptoms this visually severe, the locked jaw, the sardonic smile, the arched back, how does the medical team officially confirm what they are fighting? In an era of high-tech scans and blood tests, how is this diagnosed?
The text states unequivocally that the diagnosis of tetanus is primarily clinical. A physician observes the cephalocaudal progression, notes the characteristic spasms, and confirms the patient is conscious. That visual and physical examination is usually sufficient to establish a highly probable diagnosis.
You don't wait 3 days for a laboratory culture to confirm what is happening right in front of you.
Exactly. The text mentions that a culture of a swab specimen from the suspected wound can be done, but it's not a prerequisite for initiating life-saving treatment. The disease moves too fast to wait for microbiology.
Right.
However, the medical team is still required to run a comprehensive battery of investigations. The text outlines a full workup. A full blood count, a blood film, checking urea and electrolytes, monitoring blood sugar, drawing blood cultures, and critically performing a lumbar puncture.
The lumbar puncture stands out on that list. A spinal tap involves inserting a needle into the spinal canal to draw out cerebrospinal fluid. If the diagnosis is so blindingly obvious just by looking at the patient, why put them through the risk of a spinal tap?
Because the presentation of tetanus, while iconic, is not entirely unique. The doctors have to definitively rule out the imposters. The text provides a list of differential diagnosis conditions that can closely mimic the symptoms of tetanus. The most pressing of these are meningitis and encephalitis.
Severe infections and inflammation of the brain and its protective linings.
Both conditions can cause profound neck stiffness, intense irritability, and severe seizures that, to an untrained eye, might resemble the paroxysmal spasms of tetanus. By analyzing the cerebrospinal fluid drawn during the lumbar puncture, the doctors look for clues. If the fluid is clear, with normal cell counts and protein levels, they can confidently rule out meningitis, which typically presents with cloudy, white cell-rich fluid.
That makes perfect diagnostic sense. What else is on the list of imposters?
The text lists two incredibly potent toxins: strychnine poisoning and botulism.
Strychnine, the classic ingredient in rat poison. It feels wild to see a pesticide listed next to a bacterial infection in a diagnostic manual. How does poison mimic tetanus?
Because it attacks the same systemic vulnerability,
Yeah.
strychnine actually operates via a highly similar biochemical mechanism to tetanospasmin. It also acts as an antagonist to inhibitory neurotransmitters in the spinal cord, primarily glycine.
It cuts the exact same brake lines.
The resulting lack of motor inhibition causes severe, rigid spasms that look almost identical to tetanus. However, the doctors can usually differentiate it through the clinical history and timeline. Strychnine poisoning has an incredibly rapid onset, minutes to hours after ingestion, and it lacks the methodical, head-to-toe cephalocaudal progression characteristic of tetanus.
And what about botulism? That inclusion is fascinating because botulism is caused by Clostridium botulinum, a direct cousin of the tetanus bacteria.
They are related organisms, and they both produce incredibly powerful neurotoxins, but their mechanisms of action are diametrically opposed. While tetanospasmin blocks the inhibitory signals, botulinum toxin attacks the opposite side of the equation. It blocks the release of acetylcholine, which is the excitatory neurotransmitter.
Tetanus cuts the brakes, botulism cuts the accelerator cable.
Precisely. Therefore, botulism does not cause rigid, spastic paralysis. It causes flaccid paralysis. The muscles lose all tone and go completely limp. However, in the very early stages of botulism, the descending weakness often begins with the cranial nerves, causing difficulty swallowing and facial nerve impairment. Because this early presentation overlaps with the initial trismus and dysphagia of tetanus, it must be carefully considered and ruled out.
So the emergency room team has worked through the logic. The spinal fluid is clear, ruling out meningitis. The timeline and progression rule out strychnine and botulism. The clinical diagnosis of generalized tetanus is locked in. The patient is conscious and actively spasming. What is the immediate game plan? Because the source text transitions here into a multi-pronged management protocol that is breathtaking in its intensity.
The text structures the medical response around 6 core principles of management: neutralization of the circulating toxin, control of the spasms through continuous sedation, elimination of the residual infection, maintenance of fluid and caloric intake, provision of optimal nursing care, and ultimately, immunization of the survivor.
Let's walk through this battlefield strategy phase by phase, starting with phase 1, neutralization and eradication. The absolute first priority has to be stopping the chemical attack.
The foundational step, administered immediately upon the patient's admission, is the neutralization of the circulating toxin. We are talking specifically about the tetanospasm that has been produced in the wound, has entered the bloodstream and lymphatic system, but has not yet bound to a nerve ending.
Because, as we established earlier, once the toxin binds to the presynaptic membrane and is internalized into the nerve, it is completely untouchable.
It is out of reach of any medication. To neutralize the free-floating, unbound toxin, the protocol mandates the administration of ATS anti-tetanus serum. The text specifies an exact dosage of 10,000 units to be given via an intramuscular injection.
10,000 units of ATS to sweep the bloodstream and bind up the loose toxin. Let's use a metaphor here. Imagine the infection in the wound is a raging fire inside a house. The circulating toxin is the smoke pouring out and suffocating the rest of the neighborhood. Giving the ATS is like spraying massive amounts of foam into the air to neutralize the smoke.
I like that.
It clears the air, but it does absolutely nothing to put out the fire that is actively generating more smoke.
That is a highly accurate way to visualize it. Neutralizing the smoke is useless if you leave the fire burning. Therefore, simultaneously with the ATS, the medical team must launch a massive antibiotic assault to eradicate the active vegetative C. tetani bacteria multiplying inside the wound.
You have to shut off the gas line feeding the fire.
The text dictates a very aggressive, specific antibiotic regimen. It begins with intravenous benzyl penicillin. The prescribed dose is massive, 75,000 units per kilogram of the patient's body weight, administered directly into the vein every 12 hours for a minimum of 48 hours.
For 2 solid days, they are flooding the patient's circulatory system with high-dose 5E penicillin to rapidly nuke the bacterial factory.
Following that initial 48-hour intravenous siege, the protocol steps down slightly but maintains the pressure. The treatment shifts to intramuscular procaine penicillin at a dose of 250,000 units per kilogram, continuing for an additional 5 days.
So it's a comprehensive 7-day antibiotic eradication campaign. The ATS clears the bloodstream, the penicillin kills the bacteria in the wound. But this brings us to the most tragic, helpless reality of treating this disease. You've cleared the smoke, you've put out the fire, but the house is already heavily damaged. The nerves that absorbed the toxin before the ATS arrived are already broken.
And neither the ATS nor the penicillin can repair them. The brake lines are cut, and the patient's muscles are going to continue receiving unregulated signals to forcefully contract until the body can slowly, painstakingly regrow new nerve endings over the coming weeks.
Which means the true challenge of the medical team isn't just killing the bacteria. It's keeping the patient alive while their own nervous system tries to tear their body apart. And that brutal reality plunges us directly into phase 2 of the management protocol, the complex sedation regimen.
Maintaining profound, continuous sedation is the only viable method to control the life-threatening spasms. The goal is to chemically suppress the central nervous system enough to dampen the runaway excitatory signals without completely shutting down the patient's vital functions.
Right.
The text outlines a highly regimented use of 3 primary medications: phenobarbital, chlorpromazine, and diazepam, with a 4th drug, paroldehyde, held in reserve for absolute emergencies.
When you read this section of the text, it quickly becomes apparent that this is not a scenario where a doctor writes a prescription for a sedative and walks away. This is a grueling, minute-by-minute, 24-hour chemical balancing act that places an unimaginable burden on the nursing staff. Let's break down the actual schedule detailed in the source, because the logistics are staggering.
We begin with phenobarbital, a powerful barbiturate that depresses the central nervous system. The required dose is 4 to 6 milligrams per kilogram of body weight. Because the patient is entirely locked up and cannot swallow pills, it is administered via a nasogastric tube, a tube threaded down the nose directly into the stomach. The text dictates this must be given exactly every 6 hours.
The schedule provided is rigid. 6:00 a.m., 12:00 noon, 6:00 p.m., and 12:00 midnight. Every 6 hours on the dot, the barbiturate goes in.
But phenobarbital alone is not enough. The protocol layers on chlorpromazine. This is a potent antipsychotic medication that possesses significant sedative and muscle-relaxing properties. The dosage is 5 to 10 milligrams per kilogram per 24-hour period, divided into 4 separate doses, also administered via the nasogastric tube.
And the timing of the chlorpromazine is intentionally staggered to overlap with the phenobarbital. The chlorpromazine schedule is 9:00 a.m., 3:00 p.m., 9:00 a.m.
Finally, administered concurrently with the chlorpromazine is diazepam. This is a benzodiazepine which is highly effective at enhancing whatever remnants of the inhibitory GABA signals might still be functioning, providing crucial muscle relaxation. The dose is 0.5 to 1 milligram per kilogram per 24 hours, also divided into 4 doses.
So the diazepam follows the exact same 9:00 a.m., 3:00 p.m., and 3:00 a.m. schedule as the chlorpromazine. I want to pause and conceptualize this daily rotation. If you're the nurse managing this patient, at 6:00 a.m. you're pushing phenobarbital down the tube. 3 hours later, at 9 a.m., you're pushing chlorpromazine and diazepam. At 12:00 noon, you're back to phenobarbital. At 3:00 p.m., chlorpromazine and diazepam.
It is a relentless, unyielding cycle of chemical intervention.
It's like trying to perfectly mix the fuel and air in a massive overheating engine, adjusting the valves every 3 hours, 24 hours a day, just to keep the machine from vibrating itself to pieces. You're constantly layering different classes of heavy central nervous system depressants to keep the muscles sedated, but not so sedated that the heart stops.
And despite this immense chemical blanket, the text explicitly acknowledges that breakthrough spasms will still occur. The nervous system's drive to fire is simply too strong. When a sudden, violent spasm breaks through the staggered sedation, the protocol calls for immediate intervention with paraldehyde.
Paraldehyde, that is a very old, very harsh chemical compound.
It is a potent, fast-acting central nervous system depressant. Because the patient is actively spasming, the nasogastric tube is too slow. The text mandates that paraldehyde must be administered via a deep intramuscular injection.
Think about the physical reality of that instruction. The nurse has to administer a deep muscular injection into a patient whose muscles are currently locked as hard as concrete in a full-body spasm.
The dosing instructions reflect the extreme caution required with this drug. The dose is 0.01 to 0.02 milliliters per kilogram of body weight. The text provides a rough guideline of about 1 milliliter per year of life for younger patients.
Right.
There is a strict, non-negotiable maximum of 5 milliliters allowed per single injection site, and the total dose cannot exceed 10 milliliters.
The margins for error are microscopic. But artificially holding a human body in this state of profound chemically induced paralysis creates an entirely new cascade of life-threatening problems. If the patient is heavily sedated, completely immobile, and their jaw is locked shut, how do they sustain basic biological functions? Like, how do they eat? How do they even clear their own throat?
This harsh reality transitions the protocol into Phase 3, supportive care and the management of inevitable complications. The physiological demands on a body fighting tetanus are extraordinary.
Let's talk about the feeding requirements first, because even though the patient is lying completely still in a bed, their internal engine is redlining.
The metabolic energy consumed by continuous, unrelenting muscle rigidity is astronomical. The body is essentially running a marathon 24 hours a day while lying flat. If adequate fuel isn't provided, the body will rapidly cannibalize its own muscle tissue and fat reserves to survive. The text mandates continuous feeding through the nasogastric tube at a volume of 100 milliliters of liquid nutrition per kilogram of body weight, delivered at strict 3 to 4 hour intervals.
Let's contextualize that volume. 100 milliliters per kilogram. If you have a 70-kilogram adult patient, that is 7,000 milliliters. That is 7 liters of liquid nutrition that must be pumped through a narrow tube in their nose into their stomach every single day just to meet the baseline caloric deficit created by the spasms.
And managing the airway is equally critical. The muscles of the chest wall are stiff, making breathing difficult, so the text requires the provision of oxygen via a face mask when necessary. More dangerously, the heavy sedation severely depresses the patient's natural cough reflex, and the locked jaw makes swallowing saliva impossible.
They're at constant risk of essentially drowning in their own secretions.
Therefore, the nursing staff must perform frequent, careful suctioning of the nasopharynx to physically extract saliva and mucus from the airway. Additionally, skincare becomes a matter of life and death. The patient cannot shift their weight to relieve pressure.
Right.
The text dictates that the staff must physically change the patient's position at regular, appropriate intervals and apply powder to pressure points.
Because if a pressure sore develops, you have just opened a new necrotic wound in a patient whose immune system is already entirely overwhelmed. It's a compounding disaster. Now, despite this exhaustive, round-the-clock supportive care, the source text grimly outlines several severe complications that frequently arise,
The first major complication listed is aspiration pneumonitis.
which is the direct consequence of the airway issues we just discussed. If a patient vomits that massive volume of tube feed, or if saliva pools in the throat and it gets inhaled into the lungs, the acidic stomach contents and oral bacteria cause a massive, rapid lung infection.
It is a leading cause of mortality in these patients. Next, the text highlights severe, unpredictable swings in blood sugar levels, listing both hypoglycemia, it's dangerously low sugar, and hyperglycemia, dangerously high sugar.
I understand burning sugar quickly because of the muscle spasms, which explained hypoglycemia, but why would the blood sugar suddenly spike dangerously high? How is the body losing control of basic glucose regulation?
This is a consequence of a broader physiological failure the text refers to as autonomic instability. Tetanospasmin doesn't just disinhibit skeletal muscles, it eventually wreaks havoc on the autonomic nervous system, the background operating system that unconsciously controls heart rate, blood pressure, digestion, and organ function.
Oh, wow.
The sheer biochemical stress of the disease causes massive, unregulated dumps of adrenaline and catecholamines into the bloodstream.
So the fight-or-flight system is just dumping hormones randomly.
Yes. This constant, erratic chemical stress totally dysregulates the pancreas and liver's ability to manage glucose, leading to wild, unpredictable blood sugar swings.
And that autonomic instability leads directly to the final major complication listed in the text: acute renal failure.
The kidneys are highly sensitive organs that rely on a very stable, consistent blood pressure to filter toxins from the blood. When the autonomic nervous system is failing, blood pressure fluctuates wildly. Combine that erratic blood flow with the immense physical stress, dehydration, and the toxins released by damaged, constantly firing muscle tissue, and the kidneys simply shut down under the strain.
When you look at the totality of this picture, a patient relying on a 24-hour staggered chemical sedation loop, fighting off lung infections, their blood pressure spiking randomly, their kidneys failing, and a team of nurses manually suctioning their airway and turning their rigid body. How does a doctor standing at the foot of that bed even begin to predict if the patient is going to wake up from this nightmare?
Prognostication in tetanus is incredibly complex. The text is very clear on one overarching truth. The single most important prognostic factor is the quality of the supportive care. The flawless execution of that medication schedule, the meticulous airway suctioning, the prevention of bed source excellent nursing care is the true life-saving intervention.
The medicine doesn't work if the logistics fail.
Beyond the quality of care, doctors look at specific physiological variables. The patient's age at the onset of the disease, the length of the incubation period, the duration of the onset interval, the frequency and severity of the spasms, and the degree of autonomic instability, specifically monitoring extreme variations in the patient's core temperature and heart rate.
But the source material doesn't just leave doctors with a vague list of variables to guess from. It provides a highly specific mathematical tool designed to calculate the trajectory of the disease. It details the Hendricks neonatal tetanus score, developed in 1991.
It is a standardized predictive table, but the text highlights a critical, highly counterintuitive rule regarding how this score is calculated. Severity is inversely proportionate to the final score.
Hang on, let's make sure we understand the logic here, because that is completely backward from how almost every other medical scoring system works. Usually, if you go to the hospital and they ask for your pain on a scale of 1 to 10, a higher number means a worse condition, a high score is bad news.
Usually.
But the text states that on the Hendricks scale, a score of 0 means recovery is improbable, a score of 15 means recovery is expected. So doctors are essentially awarding points to the patient for having milder symptoms.
That is exactly how it functions. It's a measure of physiological resilience. The table evaluates 5 distinct clinical categories, assigning a score from 0 to 4 points in each category. A 0 in any category indicates the most severe, life-threatening presentation, while a 4 indicates a mild or favorable condition.
Let's analyze these 5 categories because they serve as a perfect summary of the entire pathophysiology we've just spent an hour discussing. Category A evaluates the age or incubation period.
If the incubation period is incredibly short, between 1 to 4 days, the patient is awarded 0 points. As we discussed earlier, a rapid onset means a massive initial toxin load and a highly aggressive disease process. Conversely, if the incubation period stretches beyond 12 days, the patient receives the maximum 4 points. The longer the spore took to germinate and release toxin, the better the body's chances of withstanding the assault.
Category B evaluates the onset period. This is the critical window of time between the very first noticeable symptom, like the stiffness in the jaw, and the first occurrence of a full-body paroxysmal spasm.
If that onset interval is less than 24 hours, the patient receives 0 points. The toxin is moving through the nervous system too quickly. If the interval is protracted, taking more than 48 hours to progress to full spasms, the patient is awarded 2 points. Slower progression equals higher survivability.
Category C directly measures the spasms themselves, focusing on their duration and the nature of their trigger.
If the patient is suffering from persistent, unrelenting, spontaneous spasms, they score 0 points. If the spasms are prolonged, they get 1 point. If the spasms are transient, lasting less 2 minutes, the score is 2 points. If the spasms only occur upon physical stimulation, meaning they aren't happening spontaneously, the patient earns 3 points.
Okay.
And if the patient has localized rigidity but no full-body spasms at all, they receive the full 4 points.
Category D tracks the breakdown of the autonomic nervous system, specifically measuring temperature variation.
A core temperature variation swinging more than 3 degrees Celsius indicates massive autonomic dysregulation, earning 0 points. A highly stable temperature, varying only 0 to 1 degree, indicates that background systems are still functioning, earning 4 points.
And finally, Category E assesses the respiratory complications, looking for pneumonia or atelectasis, which is the medical term for a collapsed lung.
Definite and widespread pneumonia scores a 0. Definite but limited respiratory infection scores a 1. Mild or merely suspected lung issues score a 2. And if the lungs are completely clear and ill findings, the patient is awarded 4 points.
The medical team tallies up the points across these 5 categories to get the total Hendricks score. But the text makes a crucial point about how this tool is used. It isn't a one-time assessment you do on admission and file away. The doctors are required to recalculate this score every 24 hours.
It is a dynamic, ongoing monitoring tool. The daily score provides a real-time graph of the patient's trajectory. The text is very clear. If the daily score remains stagnant, or if it begins to drop at subsequent assessments, it signifies that the current management strategy is ineffective, or that new unseen complications are developing.
A dropping score is a blaring clinical alarm. It tells the doctors that despite the ATS, the penicillin, and the massive sedation, the toxin is winning, and they must immediately alter their treatment approach.
It demands immediate clinical reassessment.
When you step back and look at the sheer scale of the medical intervention we've just outlined, the immense volumes of intravenous antibiotics, the grueling, round-the-clock staggered administration of dangerous sedatives, the physical toll of suctioning airways and managing failing kidneys, and a scoring system where a 0 means death is probable, it evokes a profound sense of frustration.
Yeah, I agree.
Because it forces us to confront the fact that every single ounce of this suffering, every resource spent in that ICU could have been completely avoided with a shockingly simple intervention. Which brings us to the final, most important section of the text. Prevention.
The source text transitions to prevention with a sentence that is almost painfully blunt in its simplicity. Prevention is easier, cheaper, and more effective than curative measures.
Given what we just discussed, that has to be the greatest medical understatement ever written.
The strategy for prevention relies entirely on active immunization. We do not try to eliminate the spore from the environment. We armor the human body against the toxin. The text specifies the standard use of the tetanus toxoid vaccine. This is typically delivered as a combination shot, commonly the DPT vaccine, which protects against diphtheria, pertussis, and tetanus, administered in a primary series of 3 doses.
Right.
Alternatively, the pentavalent vaccine is used also in a 3-dose series.
The vaccine essentially introduces a harmless, deactivated version of the tetanus plasmon toxin to the immune system. The body learns exactly what the toxin looks like, builds specific antibodies, and keeps them on patrol. If a spore ever germinates and releases the real toxin, the immune system neutralizes it instantly before it can ever find a nerve ending. But the initial 3-dose series given to infants isn't a lifelong shield, is it?
No, it is not. The text emphasizes a critical vulnerability. Vaccine-induced immunity wanes over time. Therefore, the administration of a booster, tetanus toxoid booster, at the age of school entry is absolutely essential to bump those antibody levels back up above the protective threshold.
The source material also places a specific, targeted emphasis on the immunization of girls and women of childbearing age.
This is a highly targeted public health strategy designed to eradicate neonatal tetanus. When a pregnant woman is fully immunized, her high levels of circulating tetanus antibodies cross the placenta. This confers passive immunity to the fetus, ensuring the newborn is protected during the incredibly vulnerable first few weeks of life.
That's brilliant.
It is, and it's especially critical in developing regions where the umbilical cord might be severed with non-sterile instruments, creating an immediate high-risk portal of entry.
And the final cornerstone of prevention brings this entire deep dive full circle right back to the UCH study we discussed at the very beginning.
Strict hygienic wound care. The text demands meticulous cleaning of all injuries, particularly deep puncture wounds.
If you look at the math from that UCH study, 50% of the lethal cases originating from everyday cuts and punctures, and 34% originating from neglected middle ear infections, it becomes starkly clear. Basic hygiene, immediate medical attention for mundane infections like an earache, and maintaining widespread vaccination compliance are literally the only true shields we possess.
Because the environment will never change. The spores are ubiquitous. They are in the dust blowing outside the hospital window. You cannot sanitize the earth, so you must prepare the host. It is the only logical defense against an ancient organism perfectly evolved to survive 4 hours in boiling water.
This has been an incredibly heavy, profoundly complex journey through the medical reality of this disease. We have traced the narrative from the microscopic shape of a dormant spore hidden in the dirt, all the way to the exact milligrams of sedatives required to keep a human spine from snapping under the force of its own muscles. As we wrap up this deep dive into the source material, I want to leave you with a final thought to mull over. Throughout this discussion, I've been struck by the bizarre, almost tragic evolutionary collision that tetanus represents. On one hand, we humans possess arguably the most advanced, highly evolved central nervous system on the planet. Our brains utilize a breathtakingly delicate, beautifully complex balance of excitatory and inhibitory neurotransmitters, the gas and the brakes, to perform miraculous feats of physical coordination.
Yes, true.
That chemical balance allows us to perform neurosurgery, to play concertos, to build civilizations. It is a masterpiece of biological engineering. And yet, a mindless ancient spore, an organism so rudimentary it consists of a single cell that shuts down in the presence of oxygen, can completely hijack and weaponize that magnificent nervous system against us. It doesn't need to destroy the brain. It just needs to chemically clip one single microscopic wire, the GABA pathway. By simply cutting the brake line, it tricks the human body into violently destroying itself.
That's a powerful way to look at it.
It is a deeply humbling reminder of our inherent biological vulnerability. We are incredibly fragile machines. But at the exact same time, it is an awe-inspiring testament to the power of human intellect and scientific ingenuity. We looked at a microscopic terror that has killed millions through our human history. We decoded its exact biochemical sabotage, and we figured out how to engineer a simple, easily administered vaccine that stops the hijack before it ever begins. It is a triumph of science over nature's brutality. Check your medical records, make sure your boosters are up to date, keep learning, and stay curious.